Saludos en un nuevo episodio de VETSCO PR, el podcast creado por el Colegio de Médicos Veterinarios para educar al ciudadano. Soy la doctora Sheila Vega y en el episodio de hoy tenemos a la doctora Trappler. La doctora Michelle Trappler es una de las cirujanas que tenemos aquí en Puerto Rico y esta entrevista pues voy a hacer un switch a inglés. Ella sabe español, pero la mayoría de la entrevista va a ser en inglés para poder comunicarnos fácilmente. Igual, cualquier persona que tenga alguna duda de lo que hemos hablado puede comentar en lo que serían los mini clips en nuestra página de Instagram. Sabes que nos puedes conseguir en nuestra página de Facebook, Instagram, pero puedes encontrar el podcast en lo que sería Apple Podcasts, Spotify o YouTube. Hi, Dr. Trappler. How are you?
Good.
Thank you for coming in.
Thank you for having me. I'm very excited.
We are very happy to have you today because we tried this like 3 times, right?
I think so, yes.
So this
finally,
is like...
yay!
So yeah, we did it.
Yes.
So we have here Dr. Trappler because we know that we have a lot of people, owners, that have a lot of questions about when we need to go to a surgeon or when to do an ortho consultation, etc. So we're going to start with what made you want to be a veterinarian and then be a surgeon?
What made me want to be a veterinarian, I wanted to do that since I was very young. I went through a couple things before that. I wanted to be a pilot. I wanted to be a garbage person, and then an environmental engineer, and then kind of settled on veterinarian about maybe like 10 years old. My uncle has a dairy farm in upstate New York, and I would spend some summers up there with him, and I just loved it. Like one year, there was a down cow that had obstetrical paralysis, and he was going to have to, euthanize her because he didn't have the resources to care for her, 24/7 to help her get back up. And I was like, no, please, no. And he said, okay, she's your project. So if you want to take care of her, but you have to take good care of her, and if things are not going well, then we have to stop. And that was kind of the beginning, I think. So she was my project. We got her up every single day and did therapy and all kinds of stuff, and she made it. So.
And you was 10 years old?
Yeah.
Wow.
Yeah. And she made it. So, that was amazing. And I was like, okay, yep, that's it. Now I want to be a veterinarian. So it was kind of since then. And then I originally thought that I wanted to do some kind of specialty. I didn't know if it was, surgery or emergency or what. I just
you knew that before vet school or during vet school?
Before vet school, because I started working when I was about 15. I started working in a general practice, and I was like, I'm not smart enough to know all of these things all the time. Like, to be a good GP, you have to know a lot of things about a lot of things. I was like, that's not for me. So I was like, well, I think I want to specialize. And then I started working in emergency, and I was like, oh, this is cool. I think I can do this. It's something different every day. It's challenging. You never know what you're going to get. And then that was when I was about 15 or 16. And then when I got into vet school, my first year I worked at an emergency clinic. And I was like, yeah, this is great. I love it. This is awesome. But I was working with a friend who was a year ahead of me in vet school, and he was working for the surgeon. So I would be like, ooh, what are you guys doing in there? What's happening? And, got very nosy and was like, oh, no, this is really cool. And after that, I knew, nope, I want to be a surgeon. This is what I want to do. So.
And your first surgery, what it was? Was in a horse? Was in a dog? Was in a cat?
No, in dogs and cats.
Okay.
It was small animals. So we did a lot of, it was an emergency clinic with a specialty clinic attached to it. So we did a lot of emergency surgeries. We did a lot of orthopedic surgeries. Probably my first surgery I did by myself was a cruciate, like a lateral suture. And I'm sure I did that in 3rd year of vet school because I had been working there for a long time. They knew me. They trusted me. And little by little, she was teaching me how to do stuff. And one day she was like, okay, you're going to do this cruciate.
Wow.
Okay. So it was awesome.
So for the people that doesn't know what is a cruciate, that's a knee surgery.
Yes.
Yeah. And, okay, so where did you went for vet school?
I went to vet school at University of Pennsylvania.
Okay.
And then after that, I did a rotating internship in South Florida in a private practice called Coral Springs Animal Hospital. And then rotating internship, you kind of do a little bit of everything. Emergency, cardiology, dermatology, surgery, internal medicine, neurology, all kinds of stuff. And after my rotating internship, I did not get a surgical residency. So it's okay. It happens. If anybody out there, it's happened to you, it's going to be okay. I promise. So I did a specialty internship in just surgery. So I spent an entire year working in an only surgical practice and getting more skills, and then applied again for residency and did get a residency after that.
So while you were doing that internship, you still knew that you wanted to be a small animal surgeon.
Yeah.
Because I know that a lot of people start thinking something, and when they are through it, they're like, oh, maybe I want something different. No. So you always knew.
I always knew. From that second year of vet school on, that was it.
And in your residency, do you need it to work like with other animals?
Well, no, it was small animal.
Okay.
So mostly dogs and cats. Every once in a while, we'd have a rabbit or a ferret, maybe a few birds, but mostly dogs and cats.
And once you finish with all this, what made you come to Puerto Rico?
Huh.
I already know, but
it's my husband's fault. So my husband is also a vet. He's an equine surgeon, which you know, and he's from Puerto Rico. He left Puerto Rico when he was maybe 20, I think. He was in DACVS studying, and then he ended up going to University of Florida for the second half of his undergrad, and then did vet school after that, and that's where we met. So he had kind of always wanted to come back here, and saw it in his long-term plan, but he didn't ever have like a definitive plan. And after we were both finished our residencies, we were living in Maryland, and someone from here called him, a vet from here called him and was like, hey, I'm looking for an equine surgeon. Would you be interested in coming back? He's like, I don't know. So they started talking, and during their conversations, the vet said, I'm also looking for a small animal surgeon if you know anyone. He was like, are you kidding me right now? My girlfriend is a small animal surgeon. So that kind of was like, this seems like the universe wants us to kind of try this out. You know, we don't have kids. We don't have a mortgage. Like, nothing's tying us here. You've always wanted to go back, so maybe now's the time to try it. Let's try it, and if it's terrible, we'll come back. But here we are, 9 years later. So.
By that time, do you picture yourself living in an island, like you can go to the beach anytime?
Never. Never. I mean, when this was happening, we had been dating for probably like 11 years at that point. And in that whole 11 years, I had never thought like, oh, maybe one day we'll live in Puerto Rico. It just never like really occurred to me. But here we are.
You have been here for a long time, so
yes.
I guess you like it.
Yes, I do. I love it. I love it a lot.
Okay, so when I have this pet that is coming to the GP, and I think they need to have the ortho consult, but I have these owners that they're always afraid that if they go to the consultation, they will need the surgery. So I always say to them, just go and talk to them, and they will tell you if they actually need the surgery. Why do you do that first consultation with the patient and the owner?
Okay. So first of all, you don't have to just come for orthopedic stuff. Like surgeons treat orthopedics, we treat soft tissue diseases and processes, and we do oncologic surgery. And some surgeons do neurologic surgery. I don't, but my co-surgeon does. So it can be anything that you think might need surgical intervention, or something that's sports medicine related, or any case that may need surgery that's overwhelming for a GP. Like a GP isn't comfortable doing it, or is intimidated, or is like, you know what, I could probably do this, but I want someone else to take a look. So we can see any of those things on consultation. It doesn't have to be just orthopedics, first of all. And then in terms of the consult, it's kind of, we meet with the client, we get the information from the referring vet, try not to repeat things that we don't have to, because we don't want to do that, and assess the patient, look at the dog, do a good physical exam, and then we kind of make recommendations. So yes, I would recommend surgery. No, I might not recommend surgery for you. Let's try conservative management first, or, you know, and sometimes, no, this is not something that I can fix surgically. Hopefully not those cases very often, but coming to see us doesn't mean you have to go to surgery. It doesn't mean you're committed to something. It just means we're getting another person's opinion in the care team to look at that dog or cat and make recommendations. So just because you come see me doesn't mean I'm just going to, automatically recommend surgery. We kind of say a good surgeon knows when not to cut, because sometimes doing surgery is not the right answer. And it's important that we know that. So, and if that's the case, that's what we'll tell you.
Do you have any typical information that you need from the GP in the referral when they send you a patient?
Yeah. So an important history is good. I don't need to know the dog's entire vaccine history for its whole life. I need to know, are you up to date on vaccines and heartworm prevention? What the history of this particular problem is. When did it start? How has it been progressing? What therapies have you instituted in the meantime? Have you started medications? Have you done a culture? Have you taken a biopsy or fine needle aspirate? Those things are super helpful for me to know, because the more information I have for the client, the better recommendations I can give.
There is any surgery that you say, okay, this is the most common surgery that I do, every week?
Cruciates.
Cruciates.
Mm-hmm.
And there is something in patients that are obese, or?
They tend to be at higher risk. So cruciate, we kind of touched on this, but a cruciate is the cranial cruciate ligament rupture, which is the equivalent of an ACL in humans. So a lot of times you'll hear athletes or somebody goes skiing or playing basketball, they'll tear their ACL. In dogs, it's the same structure, but in dogs, the injury tends to be a little bit different, because in dogs, it's a degenerative condition versus in humans, it tends to be traumatic. So we usually see that degenerative condition in larger dogs like Labradors, Golden Retrievers, Pit Bulls, German Shepherds. It tends to be larger breed dogs. But we can also see it in small breed dogs that also have a concurrent patellar luxation.
Mm-hmm.
So we kind of see those two groups of dogs, and I tend to treat them differently in terms of surgery. Smaller dogs, I tend to do something called a lateral suture. And in larger dogs, I like to do TPLOs. So.
And when they are in recovery, it actually helps that they are not obese?
Yes, for sure. Because in recovery, we are keeping them activity restricted, right? We're not just locking them in a cage and saying don't move, but we're also restricting their activity and having very controlled activity. So they're not doing what they normally do, going outside, running around in the backyard, chasing the iguanas. They're not supposed to be doing any of those things to protect the surgery and the repair until it's more stable. So they're already expending less energy, so they're going to get a little bit fat maybe during recovery. So really, if they're already fat before surgery and then they're getting fatter with recovery, that's harder on them, right? It's more weight on all of their joints, especially the one you just operated. So if you can keep your dogs lean in general, it's better. There have been studies done that show that dogs who are on the lean side or the thin side of normal live longer, healthier lives than dogs that are obese. So orthopedic disease, any sort of neurologic disease, any sort of ongoing health issue, dogs are going to do better if they're a little bit thinner than if they're obese.
Do you have a lot of cats in surgery, or is more dogs?
We see a fair amount of cats.
Yeah.
Yeah.
And when they're actually in recovery, once they're already fine and running, do you have any percentage that you actually know that if they already had surgery in one knee, they will need it in the next one?
Yeah.
Yeah.
So because the degenerative condition that caused the injury in the first place is in both knees.
Mm-hmm.
So if you fix one, the chance of that other one rupturing is about 25-30% on the other side within about a year. So the sooner you can get them fully weight bearing on the surgery leg, the better. Because when they're, say I did surgery on the right leg, so then in recovery they're like this, right? They're putting less weight on the right side. And they're overloading the left side. So the sooner I can get them back to equal weight bearing on both knees, the more I can protect the left one and decrease the chance of that rupturing.
And what is the rarest surgery that have you done?
The rarest surgery?
No.
Probably the one I did this morning. PDA is pretty uncommon for us to do. When I say uncommon, maybe we do 3 a year, maybe. there's other like really strange things. Maybe adrenal tumors are pretty uncommon that we go to surgery. Persistent right aortic arch, those are kind of uncommon. So I would say in terms of our caseload here, those are probably the most uncommon things that we do.
And there's any surgery that you actually hate? Like I have
Yes.
I have heard a lot of perineal hernias, but but there's anything that you actually hate doing it?
Perineal hernias are not my favorite. I do a lot of them though. I do a lot. They're much more common in dogs that are intact. So older male dogs who are not neutered are at a very increased risk of perineal hernias. That's a lot of dogs here because there's a stigma associated with castration a lot of times, or neutering, and sometimes owners don't want to do it because they think there's no reason to do it. But if you neuter your dog, the risk of multiple health issues, including perineal hernias, is significantly less. So that's my plug for neuters. Also, spays are equally important, but so we do see a lot of perineal hernias, unfortunately. A surgery that I hate doing, I hate TICAs. I hate them, especially in brachycephalic dogs. A TICA is a total ear canal ablation, and we tend to do that for chronic dermatitis, chronic ear disease. We'll do it also for masses in the ear canal is probably the two most common indications. And those are not my favorite. It's a difficult surgery. You're looking
uncomfortable.
It's uncomfortable. You're
And
looking in a deep, dark hole. There's a significant risk of bleeding. It's just uncomfortable, not my favorite. And in brachycephalic dogs, in the smushy faces, their anatomy is completely abnormal. So, a lot of times you're trying to get the ear canal and the zygomatic arch is in the way and everything's just not where it's supposed to be. So it's a challenging surgery. So those are probably my least favorite.
And when we talk about spay and neuters, I have heard a lot and I read about some papers that say that, there's always this myth, I think in the veterinary industry, if you spay your dog before the first hit, then the percentage of mammary gland tumors is going to be less. But if you have a large breed dog and then you spay it before the first hit, it's going to be not recommended due to the arthritis or bone development.
Yeah, so there's definitely some controversy, or not controversy, but kind of the jury's still out for the best recommendation in terms of spaying and age of spaying. And I think there is no one recommendation for every dog. I think it's very situation specific. It's true if you spay a dog before their first heat cycle, the risk of mammary cancer is significantly decreased, basically almost to 0%, which is obviously very good. There are some more recent studies looking at spays and neuters in like delaying spays and neuters in relation to orthopedic disease and some types of cancer. I think the cancer correlation is not necessarily proven or 100%. I don't think anybody's 100% about that quite yet. I think we need to look at more studies. What we do know is that large breed dogs, if you delay the spay or neuter until they're skeletally mature, you decrease the risk of orthopedic disease. So hip dysplasia or elbow dysplasia, maybe cruciate disease. We're not really sure. That does not tend to be true in smaller breed dogs. So for me, I think, small breed dogs, there's no need to wait. You can spay and neuter them when they're 6 months or less, and that's fine. And you're not dramatically increasing the risk of orthopedic disease. I think in an older female dog, you have to weigh, or in a female dog that's large breed, you have to weigh the pros and cons. Is this going to be a dog that's getting outside? Is this going to be a dog that could potentially accidentally get pregnant and you would have unwanted litters of puppies? Is this a dog where if it's not spayed when it's 6 months old, it's probably never going to get spayed and it's going to go on to develop mammary cancer and pyometra, cervical cancer, uterine cancer? I think if the answer is yes, that it's a dog that's at risk for those other bad things, then you spay them early. and kind of say, well, maybe I'm increasing the risk of orthopedic disease a little bit, but I'm protecting them from all these other things. If it's a large breed male dog, I think you can wait until they're skeletally mature. That's what I did for my dog. He's like a Labrador Sato mix. He's just turned like a year old a couple months ago. I waited till he was a year old because I know, he's well vaccinated. He never leaves my house. He's not going to be roaming the streets looking for dogs to mate, get hit by a car, that kind of thing. So I was like, you know what? I'm going to wait till he's a year. And then once he was a year, he got neutered. So I think it's very situation and dog dependent, and you have to kind of look at it that way. There's no black or white. In general, especially here in Puerto Rico, where we have so many problems with overpopulation, stray animals, unwanted litters, I think my tendency would be spay them. Spay and neuter them early and get it taken care of so that you're not contributing to that problem.
And for the male dog, you said that neutering him is going to help him with the perineal hernias. But
Yes.
any other condition that is actually helping when you are neutering him?
Yes, for sure. So behavior in general, we tend to see less aggression in dogs that are castrated when they're young. Roaming, smelling a female in heat in the neighborhood and running out into the neighborhood to try and find them increases their risk of getting hit by a car or running away or getting in a dog fight with some other random stray dog. So that's definitely like behavioral characteristics tend to help when they're neutered. The other thing that we see is obviously the testicles are removed. There's no risk of testicular cancer. So it definitely helps with that as well. And benign prostatic hyperplasia as they get older, they're not going to have because they don't have that testosterone influence. And that testosterone being at low levels, not having testicles, is what helps protect against the hernia because they're not causing weakness of that pelvic diaphragm. And they don't have prostatic hyperplasia where they're pushing against that diaphragm to defecate. So it helps in a lot of things.
And this question is one that I receive from owners like all the time. So if they come in and they have this pet that has a fracture, and I'm telling them, well, this fracture, we can try with bandages and the splint and everything, but I think you should go to an ortho consult. And they're like, oh, but until when I can wait to have the consultation?
No, you can't, ideally, because number one, surgery is most of the time the indicated treatment because we can have rigid fixation. So we can put those fracture ends back together, we can stabilize them and keep it stable and keep it protected until the body can heal it by itself. The body will heal it, if the bone is far away and there's some movement, the body will heal it, but not as well as if it's completely lined up, straight, the joints are where they're supposed to be, and that there's minimal movement there. That's the most effective way to get healing, is to line it up, have good contact, and no movement. So early is always better, and surgery is usually better because we get a better fixation. If you have a fracture and the bone ends are this far apart, the body's going to try to heal that because that's what it does, right? You need that leg to survive. You need it to run away from predators. So we're going to try and heal it, but it's not going to be great. So if your dog breaks its leg and you're going on vacation and you can't really deal with it right now and you come back and then you're like, okay, now I want to see the surgeon. Well, while you were on vacation, your dog was trying to heal that fracture. So it's doing kind of a mediocre job putting it back together. Now you come see me and I'm like, yes, you should do surgery for this radius and ulna fracture. Well, now I have to go in, break down all the callus, all the healing that your dog has done, and then reoppose it, line it back up. And I've already spent some of that body's, bone healing currency on trying to fix it in the bad way. Now I really need the body to go heal. I've used up some of that healing energy already, so it's a little bit harder for that fracture to heal later on. So the sooner you can get in there and fix it and have it, rigid stability, it's better. It's going to heal better. It's going to heal faster.
There is any medication or anything that the owner can or cannot do at home before going to a consultation with you? Like, for example, there is some medication that you prefer doing surgery, and if we place them as GP in some pain medication that you don't want, or you you cannot mix it.
Mm-hmm.
There is any medication that you are like, no, please don't use this one?
Medications from a veterinarian, I would say not usually.
Okay.
Like usually whatever a general practitioner starts a dog on, we can kind of work around that to get them, comfortable and on appropriate medications after surgery. The only thing maybe that would be is steroids, because steroids can affect wound healing. So if I'm doing a big mass removal and I need that skin to heal really well, maybe I don't want that dog on steroids. But if it's on it, we'll figure it out. But if you have an option of non-steroidal anti-inflammatories or steroids for a case like that, I would go with the NSAIDs. What I don't like and what's really hard is when people go to agroservicios or go to some local pharmacy and they get some injection or medication.
Or the pet shop, like
agrocenter. That we don't know what it is. We don't know what dose it is. We don't know, that's really, really hard. So if you have a pet that has an injury or a wound or a condition that needs to be seen for surgery, the best place to start is your referring vet, your general practitioner, because that veterinarian knows your pet and knows what other medical conditions it has. What is the best medication to set this dog up for success in terms of surgical treatment and recovery? So,
when you have a patient like a Dachshund that has a IBDD, a spine problem, you prefer to use the prednisone, like a steroid, or
that for me, I like to lean a little bit towards steroids. That's not really what the literature says you're supposed to do, but a lot of times we'll see these dogs, a couple days into the process, and they've been maybe on non-steroidal anti-inflammatories, and they're not doing great. So non-steroidal anti-inflammatories and steroids in dogs cannot be mixed. So if you're on non-steroidals, you have to have a washout period or a period of time where you're on nothing before you can switch to steroids, and vice versa as well, from steroids to NSAIDs. And that's because in dogs and cats, we tend to see a lot more ulceration of the GI tract and damage to the kidneys, changes in the liver when those medications overlap or are given very close together. Versus humans, it's my understanding in humans, they just give steroids, give NSAIDs. Everybody can have everything. It's no big deal. But in dogs and cats, it's not like that. So for me, I'd rather somebody start an IBDD dog on steroids, because if it comes to see me and it's not doing well, that's what I'm going to want it on. And I would rather not have to wait 5-7 days after giving an NSAID to give a steroid, because that's 5 and 7 days that dog is not getting any therapy for that. So for me, I prefer steroids for backs, definitely for necks. Every surgeon is different. So every surgeon is going to have their own opinion on that. But in our practice, we're kind of aligned with that. We prefer steroids over NSAIDs for IBDD and backs and necks specifically.
And other question that is pretty common with my owners. I have a lot of owners that, I don't know if you know, but I refer a lot of patients.
I know. I see your name on there all the time. I love it.
I have a lot of owners that ask, do they actually are going to need the CT always before the surgery? Always, obviously for a knee is not, but they always ask me that. And I always say, well, she will tell you about it. But what do you say to them when they ask about that?
For disc specifically, for IBDD
for
or
disc,
in general?
Or we can do, a mass, or do you need to know from where it's coming, or,
Right. No, you don't always need a CT. It's really going to depend. And that's where I have to evaluate that patient. I have to look at the history and, the biopsy results or the fine needle aspirate results and say, do a physical and see where it is and say, does this dog need a CT, or can I kind of figure this out without needing to go to do imaging first? For me, I prefer that they don't have a CT before they come.
Okay.
For a couple different reasons. Number one, I prefer, if I'm doing a CT, I prefer to do it in-house because I can look at it much easier. And we have a radiologist that we send all of our CTs to. And it's a lot easier for me to call him up and be like, hey, what's going on here? What's this lesion that I see on slide 152? Or tell me what you're seeing. Tell me which image to look at where you're seeing the shunt vessel or something. So he and I can have a conversation back and forth, and it's much easier for me to be able to anticipate in surgery what I'm going to find when I'm able to have that dialogue with him. If someone does a CT somewhere else, I don't have that. So I just have to go off the report, which sometimes is okay, but sometimes it's not ideal. And maybe even the images. Maybe I'll have the images, but not always. So I would prefer to do a CT in-house if I need it, just because of the logistics of interpretation and that kind of thing. And number two, if a client has a fixed budget, I don't want to spend a bunch of money on a CT and then get to the point where we need surgery and then be like, well, now I can't afford to do the surgery. Like, that's not what we want. We want to help these patients, right? So we want to try and offer the best that we possibly can within the realities of that pet's condition and that owner's budget. So if you're like, I have, $1,000 for whatever, and I spent $500 of it on CT, and now I can't afford to do the surgery, I don't get to help that pet. Versus if somebody comes to me and says, I have $1,000, I need this whatever surgery, but this is all I can spend. I'm like, okay, well, then maybe I would like a CT, but if that's not possible, we can try and do it without it. Know that the risks are, recurrence of the tumor or dirty margins where we leave tumor cells behind for some reason because we don't know exactly where the mass is, or we get into surgery and it turns out it's not resectable. We can't remove it. Those are the risks of doing surgery without a CT. But if you're comfortable with that and you're willing to accept that those are the risks, then we can try it. And at least in that situation, we get to help that pet and help that owner, even if we don't have a CT, even if it's not ideal. So,
have you needed to repeat a CT because of that? A lot of time.
Yeah, or they have a CT for a mass, and it, they had to save up for the surgery. So they had the CT 3 months ago, and then they finally saved everything for surgery, and then they come to me, and it's like,
and the mass is super big, and
this is different.
Yeah,
I need another CT.
Yeah.
And if that's the case, if it's usually like you need a CT, you have to get a surgery, then I can't. It's much harder for me to do that surgery without another CT. Versus like if you come and see me 3 months ago, and I'd be like, okay, we need a CT and we're going to have to do the surgery. And you're like, oh, well, I don't have the money right now. I'm going to have to save up. Okay, that's fine. Here's what we're going to do. You save up, and when you have the money for the CT and the surgery, then you come back. And we do the CT, send it to the radiologist, get the report back, and then we plan the surgery within a week or two, as opposed to waiting, 3 months and having to redo it. So.
And when the GP is sending you any x-ray, there is a minimum of view that you need for the lesion? Okay, so tell me about it.
So an x-ray is like it's a 3D thing superimposed onto a flat image, right? For us to reconstruct that image in our brain, it's best if we have 2 views. So at minimum, if you're taking an x-ray of a fracture, you need 2 views, right? Because one view I can see sort of, but it can change. If you turn 90 degrees, it can be a completely different image and completely different information. So for fractures, abdomens, masses, that kind of thing, 2 views. If you're doing a MET check, so if you're looking for metastatic disease from a tumor, if you're looking for spread in the chest, because of the way the lungs work, we need 3 views. You need opposite laterals, so 1 right side down, 1 left side down, and a VD, so 3 views. So you get a more complete picture of all of the lung lobes. Because on x-rays of the chest, when the side that's down, the lungs don't inflate. So if there's a tumor in the down lung, you're not going to see it. So that's why you have to do all 3 views. So fractures, masses, body cavities that are not for metastatic disease, you want 2 views. For MET checks, you want 3. Please.
Don't worry, we're going to send the message. Well, thank you so much, Dr. Trappler, for all the information.
You're welcome.
Where they can find you?
You can find me at Centro Especialista de Veterinarios at CVET. in person. And you can find me online on Instagram, dr.trappler.vetsurgery. Dr.trappler.vetsurgery. Yeah.
I'm gonna tag her on the mini clip so you guys will find her. Así que muchas gracias a todos por este otro episodio más de VetScope PR. Saben que nos pueden buscar en YouTube, Spotify o Apple Podcast. And thank you so much, Dr.
Thank you. Thank you, guys.
Bye.